The next presentation is from Professor Anil Agarwal, Laparoscopic Extended Cholecystectomy for CAGB. To Anil Agarwal, of course, requires no introduction, is considered an authority on CAGB in the country. Dr. Anil Agarwal.
Good morning, and it's a pleasure to be here. Thank you, Sanjay Mandal and the think tank of IASG to give this opportunity. And my brief is to talk about minimal invasive approach of radical or extended cholecystectomy for gallbladder cancer, difference in approach from open surgery. So I'll just take you through a few slides before I come to the video. That is that certainly feasibility was long established before actually people started doing it as a routine, or not, I mean in some centers at least. And the main concerns was that can we do it with the same radicality, and the biggest issue was that port site metastasis. But with this Professor Hahn's paper, which showed to the world that port site metastasis is not really a reality in this, and similar to other tumors, this is more technical things rather than because of cells in the pneumoperitoneum. So I think standard treatment of radical cholecystectomy, that is gallbladder cancer limited to, you would do the liver resection and lymphadenectomy, and that is what you would do laparoscopic also, lymphadenectomy, hepatic resection, and adjacent viscera involvement, which will come to later. And the basis for hepatic resection, segment 4B5, and so you can do the same in the laparoscopic. And lymphadenectomy, again, you do exactly the same and take all the group of lymph nodes, including the retropancreatic, which some of the Western literature talked about as metastatic, but Japanese literature talk about it being regional, and which is what have been, we have been doing similar to other centers. And so again, you do the same, do the entire lymphadenectomy. And so in terms of the difference, as far as the procedure is concerned, which is true for most cases, and especially so for oncology, that it is similar to open radical cholecystectomy with intra-aortic lymph node sampling, adequate liver resection, cystic duct margin, all lymph node groups, and no tumor handling. Because in fact, at the time, the literature which was talking about port site metastasis was incidental gallbladder cancer. So you might have been holding the gallbladder from where the tumor actually was. And plus, you were not taking it out in a bag. So those might have been the risk factors for port site metastasis. So it was not really fair to extrapolate that data. And we do a double clipping so that there's no bile spillage and proper instrumentation. So I think diagnostic staging laparoscopy, there's no doubt, and intra-aortic lymph node biopsy also, you can do it in this. And just, I think there was some mismatch with the so I think I'll have to run the video separately because Mac and, is it opening? Can you open it for me? Yeah, thank you. So I think you do all these steps. Now give the cursor to me. Yeah, thank you. So you do a staging laparoscopy, try to see that there's any metastatic disease. Once it is not there, you can go to the intra-aortic lymph node. In the interest of time, we'll rush through some of these. And so you just saw that sorry, I'll just come back to that. Yeah, you can see the left, just below the left renal vein. And then, as you can see that you try to minimal handle, at least not from the tumor area. This is a very old video, but because the intra-aortic lymph node biopsy video it was. And in this, we would do a double clipping of the cystic duct. And take for frozen section the cystic. And then lymphadenectomy, we take away the gastrohepatic ligament and then actually start with this 8A lymph node, which invariably is there. We lift it off from the hepatic artery, extend the incision laterally to the left side towards the celiac, along the left gastric vessel, above that. And increase the incision. This is in the anterior hepatoduodenal ligament. You can see that cystic artery, clipped cystic artery, which is there. Maybe I'll just rush a bit. And then portal vein you would dissect around that. Now that's the sucker from behind the portal vein. And now you can pass on the separated lymph nodes along the hepatic artery and to the left and take it behind and take it to the other side. You can do it from right to left or left to right. And I think when we realized that probably in this case the dissection was not complete behind the portal vein, so you can remove that and take away all these lymph nodes also. That's behind the portal vein, the sheath being dissected. And this is on the right side along the duct, and there's a big lymph node retroportal here in this one. I'll just quickly rush through this. And in the retropancreatic, and another case in which you can see these exposed vessels, but I'll just, and you can see the GDA and the hepatic, and just behind this, I just wanted to show the retropancreatic region. Okay, anyway. So, and then is the liver resection. I'll just show you in this, and then there's a separate clip for the liver resection, but this just trying to show that you take the, after segment 4B, try to take the pedicle from inside, and you can see after we have, sorry, I think I missed that part, yeah. That is temporary clamping of the segment 5 pedicle, and you can see that demarcation line. Right. Can you remove this video? I'll just come to my presentation. Can you remove this video? Yeah, thank you. I think next also video I'll play from here only. Taking the segment 4B pedicle. So the below and behind the middle vein, we'll have the segment 5 pedicle, which again will be seen in this. Now that you could see the pedicle. I realize the time is running out. So that's the segment 4B5. Remove this video, please. And go back to the presentation. Okay. I'll skip this lymphadenectomy, another video, but this is just to show that you could go from the right to the left. And the advantage is obvious in terms of, apart from if oncologically the same clearance, this is patient on day 1 post-op with a 38.5 BMI and the post-op results. And these are several series, and one of our series now, which is 200 plus in our unit, is 173 when we analyzed. 179 were the patients, and out of which 6 were converted. And out of 179, these 5 were robotic and 6 were converted. And the same thing, this is our first robotic, and in this we did the same thing, and we had very nicely this Mahesh Goyal paper in which they had 27 patients in which they have done a robotic radical cholecystectomy. And just quickly, I know there's 1 minute, so I'll just go to the adjacent viscera. And there are some papers from Gomes et al., Shirobi and Navarro about some of these resections of the adjacent viscera. And so this is just pictorially showing that this duodenum has been taken. In this, it is the colon and the distal CBD division in this case when the bile duct was excised, and the right posterior. I mean, this is our first case of doing with the hilar block. And we had a multiple anastomosis to do. And I think we are thankful to all our faculty and residents who have been with us and who have been majorly contributing in this. I'm not taking one or the other name because there are quite a few, which some of them I can see in the audience. So this is, and this is, we recently published our experience of 11 cases in which adjacent viscera was resected. And very happy to see Kale is there in the audience, and I think the only paper that I found doing a lap hepatico-pancreatic duodenectomy with right hepatic artery ligation. So that's the way to go, and I think now it is well established that the feasibility is there. There's no increased incidence of port site recurrence, and oncological are comparable from several series. So laparoscopic radical cholecystectomy is feasible with adequate oncological outcome in early gallbladder cancer and selected locally advanced gallbladder cancer patients which are comparable to open radical cholecystectomy, and minimal invasive approach has the potential to be adopted in the surgical management, and fear of early port site recurrence notwithstanding. And for tumor needing, in addition to liver resection, lymphadenectomy or adjacent visceral resection with reconstruction, minimal access approach can be safely and effectively performed. Thank you very much for your attention.
Thank you, Dr. Anil. We've come a long way from the times when we thought malignancy, GB malignancy was a contraindication for laparoscopic surgery to the present day when it's not only feasibility, but comparability is established, and we are going along. May I invite questions, not on, again, the feasibility and other things, but since these are all video sessions of techniques, any technical tips you have or you want to ask the presenter, please confine yourself to the procedural techniques, the technical matters. Anybody wants to comment?
How long does the procedure take, and what is the long-term follow-up in your experience? Because, you know, the open radical cholecystectomy is not such a major procedure, and we followed up.
The laparoscopic.
We had about when everything was clean, we had only about a 30% 5-year survival. When we followed up about 40% of all the gallbladder cancers. How long does the procedure take, and what is the follow-up?
So I think the procedure usually would be between 3 to 5 hours, and depending on what is the extent of resection or reconstruction required, sometimes it may be more, but I think it is, and gradually the time has been coming down. And the other thing is about when we analyzed in between, the results, of course, it is dependent on the gallbladder cancer in terms of what stage it is, in terms of lymph node involvement is there or not, and all those things. But I think this approach itself has not been found to be contributing towards a poor survival or a poor recurrence rate. And in fact, now in the literature, I skipped those slides because it was mainly a video presentation, that now there are several series with around 30 to 100 patients, and one of these meta-analysis of 235 patients with pretty reasonably good results. And Professor Hahn had conducted a consensus meeting in 2016. At that time, the number of series were very few, and there was hardly any series which was, his was the largest series, and there was hardly any series with more than 50 patients or so. But I think that it is moving on. Yes.
Hi, sir. This is Dr. Vikram Chaudhary from Tata Memorial.
Can you come closer to the mic? And I think
I'm Dr. Vikram from Tata Memorial. So your team is the one which is doing both lab and robotic. So maybe you are the appropriate person to comment. Maybe do you feel now that there is some benefit with the robotic approach, or you think that they are similar?
I think that's a very good question, and what I would say is that this is a question that I asked myself also when we did, because we did 5 robotic radical chole. And I said in terms of what we are doing would be similar. And I think which is true for most of the robotic procedure, because I think many years ago when one of the surgeons visited us from Memorial Sloan Kettering, he said, I tell the patient that the benefit is to me. As far as you are concerned, I am giving you the same oncological clearance, same everything in terms of the benefits of a minimal access surgery. But where I found it to be better was that I thought that it was a little more easy and comfortable when I was doing the lymphadenectomy behind the portal vein. So I think it was as though it was on the desk and you were in control, because you could leave the arm where you wanted it to, so the exposure wise and otherwise, and I think you could do the dissection in that area. It is unfortunate that because of it was in our sister hospital where we were doing, so there was a kind of a gap, and we are hoping to restart that. But I think it depends on if you are done minimal access, you are doing advanced laparoscopic procedure, then in terms of advantage to the patient may not be too much. But probably the only other advantage which I can see of robotic is, as we see in other liver resection and other things also, people who are not routinely doing advanced laparoscopic procedures probably can switch from open to robotic. Though I would still feel that laparoscopic, it's good to have the advanced laparoscopic procedure skills. Yeah.
Thank you.
Thank you. And I think maybe you want to add, because you people have the largest experience of robotic.
Lab,
do you agree with me, or
I have done very few lab radical gallbladder, so I can't comment on that. But I agree with your opinion and perception that probably the sense of control and the lymphadenectomy, ease of doing the lymphadenectomy is better with the robot. So that's my perception, but I just got the confirmation.
Yeah, and the other thing was that because this MC is so good that though I got the harmonic, but then we realized for segment 4B5 you don't really need that, and why add that cost?
So I think the combination of monopolar and bipolar is quite enough to do that.
Yes. And that monopolar is very good.
For the technical question, would you recommend any tips or tricks for the postgraduates, young surgeons, to identify preemptively the pedicles to 5 and 4B? Because time and again we realize that we have a rough idea of demarcation of these segments, and you go and dig in transparenchymally, sometimes you hit the vessels and cause extra bleeding. So are there any tricks which you would recommend?
Tips or tricks, I think there have been several papers, and Kalek had also published this paper about the ICG that he was using. But having said that, I mean, even though the tips and trick from my side would be that segment 4B, you are able to get the pedicle from outside. And then we demarcate it toward the neck. And we deepen this area so that basically you are trying to go along the anterior, Glisonian, this thing, and trying to get into the segment 5. So in fact, the landmark is when you see, if you're coming from above, when you find the middle vein, the vein going below and behind is this segment 5. But having said that again, even surface marking would be fine. And in fact, sometimes when you realize that segment 5, when you take from the clamp, it is closer to the gallbladder edge than when you do it with the surface marking. So I think we would err on the side of doing at least a 2 or 3 centimeter wedge, so to say, even on the right side, even if the segment 5 pedicle was coming very close to the gallbladder.
So most of the times you have to go transparenchymally, carefully and slowly.
Yes. And I think the other tip is that usually, I mean, one is that segment 4B when you clamp, you make sure that 4A hasn't come, because sometimes with the anatomical variation on. And the second thing is that we don't try to go on the tongue above. If sometimes that comes in, from the falciform where it is dipping, we would go straight across to the left side and try it on to match with the segment 5. Yeah.
Thank you.
The last question, please.
Dr. Sudip from Tata, Kolkata. Thank you, sir, for nice presentation. I just wanted to know that whether we should do the liver first in laparoscopy rather than doing the lymphadenectomy first. Because there are two parts. One is lymphadenectomy, one is liver resection. Is like if the conversion, if you see, your conversion is very low, but if at all the conversion happens, it will happen probably during the hepatectomy because there may be bleeding or maybe difficulty. So do you recommend that when the CVP is low, initial part of the operation, we should do the liver resection first and then do the lymphadenectomy in laparoscopy?
See, there are pros and cons to both, but I think because liver resection we're doing, there would be some amount of bleeding and the field can become a little messy. So you do it in a clean field, you do the lymphadenectomy. So that is what our approach in most of the cases. And the second thing is what we also started doing was that probably that small bulldog, we would introduce inside and probably can have a Pringle if required. But most of the time, segment 4B5, you don't really need that. But it only reduces a little bit of time and a little bit of bleeding. So I think it is both. But sometimes when it is kind of overhanging and we needed kind of space to be there, and so rather than putting extra port, it's better to get rid of the segment 4B5 and then approach that area, especially on the right side and behind the pancreas.
Thank you.
Kale, do you want to make a comment on this about the segment 4B5?
I think we are running out of time now.
Okay.
So you're exceeded.
Okay.
Yeah.
Thank you.
If I think we had a wonderful discussion. Thank you, Dr. Anil, for a good show.